Hello, welcome to the World Stroke Academy podcast series on the whole of factor 11, 11A inhibition in stroke prevention. My name is Octavio Pontes. I am a neurologist, professor of neurology at Ribeirão Preto Medical School, University of São Paulo, Brazil. I'm also the editor-in-chief of the World Stroke Academy. And it's my great pleasure to have today with me Professor Jeffrey Saver. Professor Saver is a professor of neurology at the University of California, Los Angeles, one of the most influential leaders in stroke and vascular neurology in the world. And Professor Saver has conducted multiple clinical trials, and I want to, grasp from him his insights on the future of factor 11 inhibition for stroke prevention. And Jeff, thank you so much for joining us today.
Thank you, Octavio. Great pleasure to be here.
Jeff, how do you think OCEANIC-Stroke may influence the future guidelines for stroke prevention? What's your take on this?
Well, it's certainly going to change the guidelines. It's level 1A evidence that will get into all the guidelines worldwide. The only question is how quickly will that happen, and what people should do when if they know about the trial results and the data and the new guidelines haven't come out yet. The American Heart Association is supposedly switching to living guidelines where they can update modules as they go, as some other jurisdictions have. I hope that that's the case, because that would let this be taken up very quickly.
Right. So we know that there are other trials going on, also exploring the whole of factor 11A inhibition for stroke prevention. And I would like to hear from you your expectations about in the future. Will there be any application for this strategy, even for cardioembolic strokes in the future? Do you foresee that this application, this new strategy is really a game changer for stroke prevention and it could be applied to other situations as well?
Absolutely. When you have a new hammer, right, everything is a nail. And there are a lot of nails out there right now. And the one thing we do know is that asundexian as a standalone agent against a DOAC for AFib was non-inferior, was inferior as a standalone agent. But there are many other ways to use it in that setting. One would be as an add-on agent. Another is in the patients who we are reluctant to give a DOAC to because of their bleeding risk. As a standalone agent, it would be likely better than antiplatelet therapy. And in the patient who has a breakthrough stroke on a DOAC, instead of adding an aspirin, if such people do, we could, and with doubling the hemorrhage risk, we could add asundexian. And then outside of cardioembolic, for the non-atherosclerotic arteriopathies, a lot of possible, and hypercoagulable states. Hypercoagulable state of malignancy is an interesting target, antiphospholipid antibodies, a variety. And then patients with intracerebral hemorrhage for DVT prophylaxis, maybe better than low molecular weight heparin. All of these need to be investigated.
Absolutely. And I would like to highlight, as OCEANIC was not designed specifically for this, but in the end, it's the largest trial in the ESUS population that we have so far. How do you feel like we should approach this ESUS? How OCEANIC will change the approach that we have right now for ESUS patients?
Well, the winning strategy in OCEANIC for ESUS was the combination of antiplatelet therapy and an anticoagulant. And those who were partisans of anticoagulation for ESUS were disappointed. Those who were partisans of antiplatelets, slightly, but they didn't have anything new. They were disappointed. Now we can all come together with the joint strategy.
Yeah, that makes a lot of sense. And now let's do some futurism exercise. I would like to explore a little bit. Let's go 10 years from now. How do you feel like in 10 years we will look back into OCEANIC-Stroke in terms of how the trial changed the paradigm, how we will be using factor 11A inhibition in the future?
Well, if you look back at the history of neurology and medical prevention of stroke, over 70 years, there have been 4 prior paradigm changes. There was warfarin, there was aspirin and antiplatelets, there was the statins, and then the DOACs. And now we have a 5th. So this is, once in a decade, once in a 2-decade change in the way we'll practice, and we'll look back on it 10 years from now, I think, as a signal moment in the eradication of stroke.
Yes, it looks like there's some moments that we can hear the steps of history, right? And we're so excited that we have this new tool to our, war against stroke, right? Thank you so much, Jeff, for joining us today.
Thank you so much for having me.